Good afternoon, everyone. I'm Deanna Helsher. I'm the Dean of the UT Health School of Public Health in Austin, and I'm also founding director of the Michael and Susan Dell Center for Healthy Living. And on behalf of the center, I'd like to welcome you to today's event. We are so excited to have Dr. Odoms-Young here. And you'll hear more about her later, and you'll be able to hear from her directly. But we're really happy she came down to share in this talk and share her expertise with us. So a few housekeeping things to get out of the way. If you're seated in the tables here, we're going to hold the questions until the end of the presentation. So if you're seated at the tables, if you press the, there's some little mics there that you can press so that we can hear your questions for that. If you're in the back and you have a question, we'll have someone with a microphone. So you need to speak into the microphone so that everyone can hear you from the other sites. The other thing, too, is please silence your cell phones so that we can hear Dr. Odoms-Young and everything that's going on today. So one of the things I wanted to remind y'all is the Michael and Susan Dell Center for Healthy Living has a lot of center resources. So if you're interested in any of our center resources, feel free to click on the QR code. And that'll take you to our revamped website. So with all of that, I'd like to welcome Dr. Shrila Sharma, who is Professor of Epidemiology and a Dell Center member, to the podium. So she's going to talk a little bit more about Dr. Nader's legacy. Prior to doing that, I did want to mention that Dr. Sharma and her husband have an endowed fund for excellence in community nutrition, health, and wellness. And so as you can see here, they've done such an excellent job of funding students, most of all, I think, who have published in this area. So really done a great job of guiding them and providing financial assistance as well. So if you could join me in giving a round of applause for the Sharma Fellowship. And now for Dr. Sharma.
I think the mic is on. Welcome, everybody. Before I introduce Dr. Odoms-Young, I wanted to talk for a few minutes about Dr. Phil Nader, without whom this lectureship would not be possible. And it's wonderful to see so many friendly faces in the audience. For those of you who did not know Phil Nader, he dedicated his career to the advancement of child health, and his contributions to our understanding of early life cycle systems cemented his legacy of health. The aim of this annual lectureship is to promote and strengthen the nexus between health theory and practice in two ways. First, the Nader Legacy of Health Lectureship is designed to educate and inform academics, providers, public health students, and community members about early life cycle systems. And today we are fortunate to learn from and be inspired by Dr. Angela Odoms-Young of Cornell University. Second, this event is intended to stimulate cooperation and collaboration among physicians, patients, family, and the community. The goal is to move towards improved health status for our communities, our parents and children, and everybody that we have the privilege of serving. So it's a legacy of health for generations to come, which was the vision of Dr. Phil Nader. And I had the privilege of working with Dr. Nader, and so did Dr. Helsher and many of us here. And he was truly inspirational and completely committed to serving the community and keeping his patients and families at the center of everything that he did. All right, so now I have the pleasure of introducing Dr. Angela Odoms-Young, our keynote speaker for today. Dr. Odoms-Young is an associate professor and director of the Food and Nutrition Education in Communities program at Cornell University. Her research centers on understanding the social and structural determinants of dietary behaviors in low-income populations and Black, Indigenous, and people of color, and identifying culturally appropriate programs and policies that promote health equity, food justice, and community resilience. Dr. Odoms-Young has over 20 years of experience partnering with communities to improve nutrition and health, and has served on numerous advisory committees and boards, including the Institute of Medicine, to revise food packages provided for WIC and the Council on Black Health. Some of you may have heard her last week at the White House Conference on Hunger, Nutrition, and Food Insecurity. Dr. Odoms-Young also currently serves as the inaugural Equity Visiting Scholar at Feeding America. Please join me in welcoming Dr. Angela Odoms-Young.
I think I will use this. Yes, yeah. Thank you so much, and thank you for the invitation. It really is an honor to be here. Anytime I get invitation and an opportunity to speak as well as connect with colleagues, most of the time I take it, but it is really an honor to think about a lectureship of Phil Nader. What a legacy, when it says a legacy of health, because I definitely was a fan. We have to really think about the people that set the foundation before us, and really we follow in that legacy. And then a lot of you will follow to continue to build that legacy. So today I'm gonna talk a little bit about some of the work that I've been doing, but a lot of the thinking that I've been doing along with other colleagues to think of how do we move towards equity and liberation in the field. So I'm going to talk about applying a liberation nutrition research lens to address racial and ethnic disparities in dietary behaviors and related health outcomes, and really the implications for research practice and training. And I'm hoping a lot of that really comes in the conversation that we have. And that you serve as a thought partner with me as I give this presentation. So I just wanted to include that, and just, again, a legacy of leadership. Before I get started, I want to acknowledge that Cornell University is located on the traditional homelands of the Guyacono, and the Guyacono are members of the Haudenosaunee Confederacy, an alliance of 6 sovereign nations. This is really important when we think about equity, because our past informs our present and informs our future. And so what I would really like to talk about today is that we can't get away from the past. A lot of times we intervene for now, we want to intervene right now and make a change, but we can't make a change unless we understand history and communities. I also want to just acknowledge, based on my history, the MIAFA, which is the transatlantic slave trade. I would not be here if it wasn't for the transatlantic slave trade. And so the positive and the negative of that, of millions of Africans that were uprooted from their homeland and brought to the Americas, and the significant impact on that, of that, as far as the legacy, my own personal legacy, as well as the legacy of the communities that we work with. So I'm going to start out by just giving an overview, talk a little bit about background, give a few examples, and then discuss reframing the problem. Applying a liberation lens is not unique to the suggestions that I have. Liberation lens is in several fields: theology, sociology, psychology. So they all have a liberatory praxis as part of their fields. Give an example of a project that I'm working on in Chicago called Amani Village, and then really within our discussion to go to next steps. It's so important that I have this diagram. We know that a needs assessment is important, goals and objectives are important, what methods we apply become important, but problem identification is really where it starts. If we don't understand the problem, then the direction that we take may not go in the direction that we need to, because if we don't understand what is the problem, that really is the origin of our work. So most of my work is around health equity, as well as looking at structural oppression in the context of public health, specifically nutrition. And it's well documented. It's not unique to the Americas or the United States that for decades, indigenous populations and people of African descent, if you go to Canada, I've talked with some colleagues in Canada, you see Afro-Caribbean, Afro-Canadian, or Black Canadian, African-American, Afro-Latinx. You go across and you see both indigenous populations and people of African descent in the diaspora disproportionately bear the burden of ill health globally. And really, we've seen a lot of this with COVID. COVID lift the veil on people really wanting to understand, those that may not have traditionally focused on understanding oppression in disparities, where we have Black, Latinx, and Native American populations disproportionately bearing the burden of COVID, including hospitalizations, infections, so both morbidity and mortality, based on these long-standing systemic health and social inequities that exist. And so this is not new, and I'm sure it's not new to you, but it's important that we unpack and understand the implications of this. We see a reduction in life expectancy in 2020. Part of this is due to COVID, but you see the disparities that exist. So trends in life expectancy at birth, and we see just the impact of COVID, but also the persistent inequity that exists, or disparities that exist in morbidity and mortality. And so I'm going to talk a lot about Black Americans because that's where my work is centered as an example. But I want to emphasize, and I'm going to move around because I always have a hard time like standing. But I want to emphasize that this is an example. It could apply to multiple populations. And so it's really a case study where Black Americans have higher rates of heart disease than other ethnic groups. Again, when you look at that burden of health, over 40% of Black men and women are diagnosed with hypertension. 80% of Black women are classified as overweight or obese. And again, this should not be surprising. Black Americans have the highest mortality rate of any other racial group when it comes to cancer. Non-Hispanic Black Americans have 2.3 times infant mortality. And this is the bad news. So I want to get to the good news, what we can do about it. But again, a lot of these things have persisted over time. And part of our framing has been related to individual focus, not on systems and structures. So I want to give a few examples and really dig deeper because, as I mentioned, my focus is nutrition. And I have three examples that I really want to highlight. One is the example of obesity, the other is food insecurity, and the third is food access. And so what does this mean when we start to dig deeper and think, particularly in our field of nutritional sciences, of those issues that are very salient to us? And obesity is one of those things. The burden of obesity, as was mentioned, I was at the White House conference and spoke at the White House conference. And part of the motivation between the food and nutrition security emphasis is about the burden of chronic disease, and obesity is one of the things at the center of that. We also see in every newspaper the obesity crisis, and COVID probably was one thing that came into play and that we started to talk about more, but that was also related to obesity and the discussion about the burden of COVID being more severe as it relates to obesity. This was just released in September, and you probably are aware of the famous CDC maps. The recent maps were just released about 2 weeks ago, and you see the prevalence of self-reported, and this is self-reported obesity among U.S. adults by state, territory, race, and Hispanic origin based on the Behavioral Risk Factor Surveillance Survey. The map on the left, on your right, is overall. So you see geography, of course, you see that disparity. We're in Texas. You see that disparity that exists. But once you start to look across racial and ethnic groups, you see a greater burden, as we talked about. In obesity, again, this is the latest maps from the CDC, and you see the map on the left, your left, is non-Hispanic Blacks. And again, you look across every area. So you have a regional disparity, and you also have a racial disparity. And you still see, again, the regional disparity when it comes to non-Hispanic whites, but you see a difference. Anybody who looks at the color of these two maps, immediately you see the differences. Again, and we don't highlight, I'm not going to focus on American Indian and Alaska Native populations, but you see a similar pattern between indigenous populations and African people of African descent in the United States. And in this case, in some areas, you see a very significant burden of obesity. And then also Hispanic populations or Latinx populations, you see that difference. And particularly in those areas, you see Texas, that exists. So again, with Hispanic or Latino populations, Latinx populations. And then although you see the lower burden in Asian populations, again, I'm not going to talk about Asian populations, but this only tells half the story. We know once you start to disaggregate, the story may be different, but they have the lowest prevalence of obesity. What is particularly striking about the report that came out was just the persistent, really population, difficult to change impact of obesity, where 10 states among 48 states and territories with sufficient data had an obesity prevalence of 35% or higher in non-Hispanic whites. Again, you know the story. And this story is striking, again, when we talk about race and ethnicity. This is from NHANES data. And you see, as I talked about before, just the disparities that exist when it comes to obesity by race and also severe obesity. But I know you're thinking, let's get to the good stuff. How many people have not heard that disparities in obesity exist by race? Yeah, not one person. How long have we been talking about this, right? So part of it is really understanding where it falls. What is the driver? And so most data is comparative. It's comparative by race. And so there's always this discussion about what is the origin. Years ago, Richard Cooper's group, which is now led by Amy Luke, they did studies across the African diaspora. And it's like, who is the comparison group? So if you look at the comparison group, when you compare white as the reference group, in this case, US Blacks are the reference group. And you see, again, US, UK, as compared to the continent, you see that disparity that exists. Now, this is a little older. It was from a study that they did in 1995. But I think when you look at that level of difference that exists, what's happening in the US and secondly in the UK as a driver? Is it diet? Is it individual behavior? Is it systems, as we talked about? And so let's dig deeper into that. So even though a lot of our work has started to think more about systems, we still in our brain, even in my brain, is being trained in nutritional sciences, this problem of choice versus chance. Do people choose the hamburger or do they choose the fruits and vegetables? Part of what we do in a lot of our interventions is to make the healthy choice what? The easy choice. So most of our work is rooted in choice, no matter what, honestly. It's not necessarily rooted in chance, but the idea is that you can create more chances for people. But how far do you move beyond choice? And that's difficult, honestly. It's difficult for me. It's difficult in our training. We're like choice, choice, choice. People do make a choice, right? That's the idea. But we really have to start to think about and move up, 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 up. And this is James Baldwin, who's definitely Fire Next Time is probably one of my favorite books. But he had a quote, "Not everything that is faced can be changed, but nothing can be changed until it's faced." And it goes back to that problem identification. So where are we looking? Are we like this guy with the magnifying glass? Why is he looking at risk factors and behaviors when the key lies in the social determinants? So everybody has seen this or a version of this. So what does it mean when we say move upstream? How far can we go? Downstream, we are still very much focused downstream or midstream, honestly, when we think about the scientific base of our interventions. So mortality, disease and injury, what kind of risk behaviors are drivers of these outcomes? So part of it is in reframing. And if we don't reframe, then it's difficult for us to think about the choice or chance. And they've done a very good job in violence prevention about reframing. And my argument is actually nutrition and food and nutrition security is similar to violence, because the intentional use of physical force or power, threatened or actual against oneself or another person or against a group or community that either results in a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. Would you say that's nutrition in the United States? How many deaths are associated with poor diet in the United States? Actually, Dari Mostafarian published a paper about the significant deaths in the United States from nutrition. And so part of the reframing is thinking about nutrition as violence. Violence prevention used to focus very much on individuals. But Johann Galton, and this is actually from the 60s, I think, the idea of structural violence. So if we think about nutrition as an individual, nutrition as violence, and we reframe it as structural, the idea that structural violence is what's at the root of violence, not individual decision making. So what is structural violence? So structural violence is a well-known concept. Johann Galton's triangle of violence, so where we have direct violence, again, that's what we see, structural violence and cultural violence. In the direct violence is those physical or psychological violence, again, diet as a kind of a psychological or physical violence. And then the policies behind those are structurally violent. It highlights the negative consequences of an uneven distribution of power and resources, to understand these largely as avoidable. and not just given. So sometimes, honestly, again, even I have a difficult time. And my mentor, Shariki Kumanika, she said at a conference, and I'm like, she said, is the world ready for black people to be healthy? And I was like, I never thought about that. That's kind of simple. But again, the narrative of BIPOC disadvantage, the narrative of low income disadvantage, that is our narrative. Are we ready for that narrative to be changed, honestly? Are we ready for it? Of course, a lot of our work, including mine, is built on it. Maybe I want to study Black joy. Maybe I don't want to keep studying disadvantage. You know, maybe let's flip it. So the idea of dealing with structural violence, you know, is to really look at how do we address that direct violence through looking at what's below. The structural violence and the cultural violence. And the most famous, you know, who recently passed away, he looked at this a lot with HIV, and that's Paul Farmer, which some of you may be familiar with. So structural violence is a form of violence wherein some social structures or social institutions harm people by preventing them from getting their basic needs met. So when we think about direct violence, what we see, structural violence is collective. It's not individual. It's targeted against certain social groups. It can be difficult to identify. And it manifests as economic, things like exploitation, political. It's a process, and it tends to be faceless in many cases because it's easy to intervene with individuals, but it's harder to intervene with structures and systems because really it takes a different skill set a lot of times than how we've been trained in the theories that we have. So how do we flip that? So if we think about nutrition as sort of direct violence, so we see poor nutrition, we see diet, we see food insecurity, we see physical and mental suffering. Because if you've ever been in a hospital or you've ever had a relative that had cancer or diabetes or hypertension, we know that that's physical suffering and family suffering, death and disability, individual and family trauma, and then negative aesthetics in low resource communities. We can come into communities, that's extraction violence. What people talk about is extraction violence within this idea of structural violence. And then we have cultural violence, narratives of inferiority or ignorance in communities, anti-Indigenous and anti-Black racism. And then these policies that have existed for many years. And I want to highlight a few of these policies in my examples. So part of this structural violence is structural oppression. Systemic and structural oppression are really forms of oppression. And how are we intervening? And a lot of times I don't want to talk about not doing. It's additive. Right now we have to do individual interventions. Why? Because people are suffering. But where are we going? So what's now and what's... I think it... Ask somebody to mute.
Yeah.
Can you mute?
Brownsville, can you mute?
Brownsville? Brownsville, can y'all mute your room, please?
Oh, that. Okay, I think they muted. Okay. So this idea of structural oppression is, it's pervasive and it's deep. So again, we're intervening for now, but we have to understand that there is this system that exists. We have racial segregation, of course, is a good example, unfair lending, housing. We have several of these that we can talk about. And again, racism is one of those forms of structural oppression, but of course there's others. So we have these levels of racism that exist, and most of you are probably familiar with this, Kamara Jones's levels of racism. So we have internalized racism, interpersonal racism, institutional racism, and structural racism, all which manifest itself. We've had a lot of talk about structural racism this year, but really internalized racism is really as important. All of these, I wouldn't say that they're, I mean, of course, structural is a driver, but they're all important. If you have what people talk about, if you feel inferior, that is a problem that needs to be addressed. Interpersonal racism, all of these factors, and institutional racism, can you get access to those things that you need? So there's several pathways, and this is from 2017, a National Academies of Science report that looked at 2 pathways by which racism, again, an example, and other forms of structural oppression impacts health. One is through disparate treatment, direct racism. People are discriminated on the basis of race. But I think the other one becomes even more important in our context because it's treatment on the basis of inadequately justified factors or characteristics that disadvantage a community. So in this case, and it could be anything, but I think a good example is mass incarceration. So if you look at mass incarceration, there was disparate treatment on the basis of race, but then when you discriminate based on incarceration, that really is treatment on the basis of something that's not race, but inadequately justified, and communities may face both, the layering. So why is this important? How many people are nutritionists here? Nutritionists, nutrition scientists, people that are focused on nutrition. I know a lot of interns are here. Dietitians, where are my dietitians at? Okay, yeah. So the idea of we have an identity, of course. So all 3 of my degrees, I'm not a dietitian, but all 3 of my degrees are in nutrition. So we know, from undergrad, grad, you really have an identity that goes along with what? People at parties come up to you and they say, what? Tell me what to eat. They think you know about. And then it's like, even now I'm like, I study structural oppression, of diet. They're like, okay. Then they come up to me and say, can you tell me about food deserts? So at the party, so you have this identity that goes along with food. So how do we move from food to structural violence? So the understanding about the relationship between structural oppression, diet, and health is really important because it's more than just nutrients. We have to know nutrients. You have to know micronutrients, macronutrients. You have to understand nutrients. But how do we think about diet? We can't separate food from people, and we can't separate biological processes, physiological processes from people. So dietary practices, food consumption behaviors happen in bodies that have been impacted by oppression. It's not separate from bodies. Historical and social, physical and marketing contexts have an impact. And then individual and community capacity, again, has been impacted by structural oppression, what we can do about it, what people can do in community. And then food identity, culture, culinary traditions, and agricultural traditions. If you ever walked in a community, those are tools of oppression. This is how oppression occurred. It wasn't separated from food. Agricultural practices. Cultural violence is stripping somebody of their traditional diet. So part of cultural violence is already a part of our field, except we don't always think about it in that way. The way diets came about is through cultural violence. People deemed as being inferior, diets deemed as being inferior, people being moved off of land, moved to other land. And so we have to understand it in the context of more than just nutrients. So I want to go to a couple of my examples. And make sure to, okay, good, okay. So food insecurity is one of those examples. It's a household level economic social condition of limited or uncertain access to adequate food. Hunger is an individual level physiological condition. So again, it was a move from including hunger to levels of food security. So very low food security and low food security are what's considered food insecure, while marginal food security, although marginal food insecurity does have an impact on health, and high food security are what's considered food secure. We've introduced this term nutrition security. So nutrition security is a situation that exists when all people at all times have physical and social and economic access to sufficient, safe, and nutritious food that meets their dietary needs and food preferences for active life. This is a USDA definition that exists. And thinking about nutrition security, and food security, and then emerging focus on nutrition security. But food security as compared to food insecurity is really a multidimensional concept. When the concept of food security was developed, it came originally from a study of Kathy Radimer, was very influential in thinking about the concept of food security and food insecurity. It was done in low-income white population in upstate New York, and they talked about what they experienced. So we talk about food security, and now we talk about nutrition security. A lot of that is physiological. Again, rooted in the idea of nutrients. So do people have adequate nutrients? But it really is a multidimensional concept. It's psychological. So people experience food anxiety, feelings of deprivation or lack of choice, experience of running out of food and not having money to buy more, deviation from social norms. We're what? Doing what? We're eating lunch, we're socializing. When you don't have food, particularly in certain cultures where food may be the basis of connection, it's a deviation from social norms, and it also can lead to social exclusion. Powerless, guilt, and shame, engaging in strategies that are beyond food, managing processes, including delaying bill payments or needing to engage in things that would be viewed as socially unacceptable. And we've done studies with families, and there is we talk about trauma, but there's also this idea of shame, which is emerging as shame-sensitive interventions. The physiological is, of course, obvious. Adjustment to normal food use, reduced food intake, physical sensation of hunger. And I think President Biden said it at the White House conference, what would happen if you couldn't feed your child, and the feeling of that. That was one of the things that he mentioned at the White House conference. So just the anxiety, the shame that goes along with that. So part of food insecurity in the United States is racialized. We've had a lot of discussion around COVID, but these disparities have persisted for years. This is from 2008. And from 2008, the rate of food insecurity for Black households has been more than double that of white households, period. It is. It has been more than double. And again, I'm using Black as an example, but we see in other BIPOC populations, particularly Indigenous populations, similar disparities. So what is the root of this, and how does structural violence play a role? This is a report from a colleague, Mariana Chilton at Drexel, that measured experiences of discrimination, and this was in Black, white, and Latinx caregivers. And she found that more experiences of discrimination were related to higher levels of household and child food insecurity. And so you see 3+ experiences of discrimination. She also looked at in-sector discrimination. So part of this is evidence. And again, I want to get to the good stuff, the solutions, but talk a little bit about the evidence in these examples because there's several studies that link discrimination or experiences of discrimination to food insecurity. So do we educate? I'm a nutrition educator. We educate, we talk about food resource management, which is critically important. That's critically important. But how do we continue to move up? Because if people that face discrimination are more likely to be food insecure, how do we address discrimination? Second example, food access. We say low food access areas. People say food deserts. They say food swamps. It's several terms. How many people have not heard of food desert? Anybody, when was the first time you heard the term food desert? What year? 2006, 2008, 2012, 2001. I heard somebody say 2001, 2004. How many years ago? Let's use 2004 as an example. How many years ago was 2004? 18 years. So 18 years. And of course, if you go to the community, people are like, okay, we know low food access areas existed. And part of them have continued to persist over many years. This is several places. New York, in Ferguson, photos. This is most recent, that intersection between state-sanctioned violence in corner stores in the case of George Floyd. But you wouldn't think 1960s, 1970s, same story. There was a U.S. report on what we now know as food deserts in 1969, a congressional report that linked to what they used to call ghetto groceries. And so in the marketing literature, and there's several, costs of food in black and whites, a survey that was done in 1971, in 1968, consumer problems of the poor, and a lot of this was racialized. How many people know what happened in 1992 in Los Angeles? Riots. So grocery stores, and a lot of, if you look at just sort of traditional pictures across the idea of structural violence in communities, there's a reason why people destroy grocery stores. So if you look at the grocery stores and limited access, how structural violence plays a role in communities, low-income communities and communities of color, that one way, again, I said food is structural violence. It's not just in the past, it has existed over time. And so this is, of course, after Rodney King, and in limited food environments already, what you see after certain things that happen where you have racialized or state-sanctioned violence, or this is what, in 1968. This was after the death of Martin Luther King. In stores, remember, as I mentioned, in 68, the same problem existed with low food access. And again, it's persistent, so it's not new. So the idea about structural violence is longstanding. So, okay, I'm gonna move ahead so I can make sure that I talk about the good part, but again, this complex relationship that exists. And the last example that I'm going to highlight very quickly is obesity, as I mentioned. And there was a paper, and we talked about it earlier, about the contributors or causes to obesity. And this is from the Obesity Society. This is what's inside the person and what's outside the person. But of course, structural violence is not located on this map. How does structural violence shape risk of obesity? Again, we think about behavioral causes, But one of the factors that we don't always consider both in diet and more work is coming out as it relates to that is chronic stress in the microbiome. So there's a lot of work that is coming out about gendered violence and the relationship, racialized violence as it relates to the microbiome. And this is just two papers that came out last year about Black women report higher levels of psychological stress than white women and carry the burden of chronic conditions. And a lot of this science that's emerging is related to the microbiome. And so the importance that we keep that bridge going in the gut and brain axis. And so science is emerging that supports more and more in us understanding structural violence upstream as it relates to downstream, environmental exposures, and I won't talk as much about that. So what's the good news? So part of what I've been proposing is to have a liberation lens, bring a liberation lens to nutrition, moving beyond the belief that science is objective and that knowledge is neutral. But it's rooted in privilege and a hierarchy. We have to acknowledge our role in the trauma. And one of the things as a Feeding America Equity Scholar, and also in thinking, one of the things that some of the food banks and folks at FANO have talked about is this idea, what role do we play and how do we reframe that? How do we reshape that as a national organization, very robust organization of food banks that exist in communities? How can they reshape their role? Acknowledging that race is a social construct. We say that all the time, but when you look at the literature, it shows up as a biological construct. Embracing intersectionality, we don't have a luxury to continue to be very simplistic when we think about structural violence, and avoiding a reductionist approach. And so I want to talk about a few of these. Understanding systems of power and rejecting a deficit lens in community. Although we talk about strengths in community, we go in as experts. I know I've done it myself. People are probably like, listen, who are you? You know, it's like, I got a PhD, so what? You know, it's like, and actually some people in my family, they're like, oh yeah, okay. So it all is like, we're so proud of you till you start showing up thinking that you could tell everybody what they're doing wrong, you know. It's like, oh, you went to Cornell, so what? We remember when you were like 5. So part of it is thinking about not bringing a deficit lens, but highlighting Indigenous knowledge and really thinking about Indigenous knowledge and local knowledge equal to, or even in some cases better than our more Western approaches to, or scientific approaches. Facilitating collaborative and equitable leadership, understanding local experiences. And so I want to talk about a few of these, but the last two are really just conceptual. Understand that oppression is intergenerational and has transgenerational effects. So can you move the needle in one generation? We try to move the needle in one study for 8 weeks. It's like, you got this 16-week intervention and we want outcomes. You know, it's like, we want outcomes, you know, forget the years and years of oppression and structural violence. It's like, if you don't get outcomes, you know, we don't want you to publish this in a paper. We want to see results. And then, is the outcome healthy eating or is it liberation? We really have to figure out what is the outcome. Our outcome is liberation. And in Johann Galton's model, it's peace, because liberation is peace. Those are peace studies. Structural violence are peace studies. So if you begin with that end in mind, how is it reframed? So I'm going to talk about these pretty quickly. Okay, thanks. There's been several books, Indigenous Food Sovereignty in the United States, Restoring Cultural Knowledge, Protecting Environments, and Regaining Health. There's also High on the Hog, which some of you may have seen, that highlight the tradition. So really acknowledging our role in the trauma. It's difficult to show up to a community when really, even in some cases, universities have caused harm. And part of reconciliation is acknowledging that. I'm here to help, but I know we cause harm. And so structural and cultural violence, we have to recognize how colonization disrupted traditional food systems, land dispossession, in some cases, university land dispossession. I was in Chicago for years, and our university was built on the dispossession of land. A lot of universities are built on, Cornell, for example, has a significant amount of indigenous land. It's been documented. And so part of this idea about structural violence in the past is that universities also have been part of that structural violence. And how do we acknowledge that? Years of oppression and intergenerational trauma, to have a more asset-based approach. Again, one thing goes hand in hand when we think about knowledge and valuing knowledge. Science, for example, again, understanding what role we play, who's conducting the research and for what purpose. Of course, there's extensive literature on scientific racism. The racial hierarchy was actually based on science. And he's deceased now, but Bill Jenkins, who was an APHA for many years, who was one of the people at the CDC who helped uncover the Tuskegee experiment. He did a presentation at APHA that some people who go to APHA often may remember, about Tuskegee as community-based participatory research. It is one of the best talks. I was like, what? I'm like, I'm CBPR. And it was like, oh yeah, Tuskegee was CBPR. And we don't think of it. I was like, in the basis of Tuskegee and eugenics. So part of this idea about science is really important, that we understand the history and legacy about science for what purpose, and we still have that racial hierarchy within our scientific models. And some of the scientific models, again, have led to theories that can be reframed, but also other things that are harmful, systemic discrimination on the basis of science, and even in some cases, genocide. So if we say race is a social construct, and there's been several papers this year about race as a social construct, not a biological construct, and the importance of carrying that through in liberation research. This is an excellent paper that came out last year called Chasing Ghosts, Race, Racism, and the Future of Microbiome Research. And in the paper, the investigators argue, it's a commentary, we argue that careful examination of the human microbiome science's relationship with race and racism is necessary to foster equitable social and ecological relations in the field. What they did is they looked at the increase in the use of race in microbiome research. And so the importance of understanding racism, and they make that argument, is race a biological construct? And I think that's very important as we move into precision nutrition, to think about, is it race or racism? When we think about, and they make some good suggestions about ghost variables. So the idea of ethnicity versus associative factors or structural drivers. So again, is it outcome liberation, or is it better eating, or potentially therapeutic approaches, again, which are very important, but we have to understand those in the context of structural violence. So a few others that are part of this thinking and shaping as it relates to a liberation lens. One size doesn't fit all. Intersectionality is critically important because it looks at layering of oppression, and we aren't measuring a lot of these. We aren't measuring class, a little better, race and class, colorism, sexual orientation and heterosexism. We looked at studies that measured even sexual orientation or gender identity. And a lot of studies don't measure gender identity. If you look at risk for food insecurity within group, this was a combination of just an article that came out from a Gallup daily tracking of adults that showed that LGBTQ plus populations were at great risk even within group. And Black sexual minority women were more in this second study, more than 2% is likely to report food insecurity. And so this intersection of oppression, how does cultural violence play a role? The Liberation Nutrition Research lens advocates not using a reductionist approach. We can't reduce people to just their mouths. Thank you. So people live in, mouths are in bodies, bodies are in households and in communities. So when you go into community and you talk about insecurity, in some ways, particularly we understood this year, and you look at both in the United States and Canada, missing and murdered Indigenous women. The idea of being insecure because of your very existence. Earlier, we talked about transgender women. You're insecure because of your very existence. And food insecurity is part of this. This missing person of Jelani Day is an excellent example of the value of, it took so long for him to be found. And it was really his mother who advocated because they thought as a Black man, he just up and left. You know, it's like, well, he's a graduate student. He didn't just leave, you know, and it took so long for him for them to find him because of the value and the thinking and stereotypes. So it's important that we understand it in the context of this broader community. Communities are also complex systems. They're complex adaptive systems. And so it's important that we look within this context, that we can't just look at part of the community. We have to look at community as a system. And so I know I have 5 minutes and I'm gonna just talk about a couple of these quickly. I already talked about social power. But the importance of a liberation nutrition lens to think about power building. How do we think about our interventions? Do we train students in power building? I know that that's not in community organizing. And also making sure people are equitably at the table. And so I really want to close with this. And I love this diagram because this is another one of those equity diagrams. Of course, inequality is unequal access to opportunity. Equality is evenly distributed tools and assistance, but of course, if the tree is too high, then a person is not going to be able to reach that. But we can give tools to help, custom tools that might be different based on needs to address inequality. But when are we going to start bending trees? So liberation is really about bending trees. And I'm just going to give a shout out to Imani Village, which is a sustainable, eco-friendly, mixed-use, green intergenerational community with a village environment where church, African-American church, purchased 30 acres of land on the south side of Chicago to create a community that addresses all of the social determinants of health. And part of this is really thinking about, now I was invited in to this project. This project is conceptualized by community. And it's important when we think about liberation is supporting not our projects, but supporting community projects. This is Otis Moss III, Reverend Dr. Otis Moss III, who is a minister at this large church of 8,000 members. But they purchased the land through church investment, individual investment within the church. in addition to leveraging other types of investments now as the project is developed. But this is the site example of it. And I think that these are really about bending trees. How do we show up within community to help support liberation work if our outcome is liberation? And so I'm going to end there. Thank you. Thank you.
Excellent presentation, and so nice to see all of y'all here. So, does anybody have questions for Dr. Odoms-Young? And if y'all are at the regional campuses, feel free. Maybe we'll start from there. Does anybody at the campuses have a question? Okay, I can tell y'all are thinking. So anybody here have questions? I have some questions, but I thought I'd open it up first. Yes.
This on? Thank you so much.
Press it down, yeah, and keep it pressed.
Okay, I have lots of questions, but I'll focus on one really about framing or thinking about reframing. So I'm an early career faculty member. You may know where I'm going. It can be really hard to reframe journal article manuscripts and grants to really contextualize work in nutrition in a way that acknowledges social, structural, and systemic factors, whether it's in the applications themselves or in the manuscripts, or especially through the peer review process. So what advice or tips and things might you offer as how we can kind of be prepared for resistance and do things differently?
Good point. And honestly, it can be difficult. I'm not going to sugarcoat it and act like it's not difficult. You know, there is meantime and there's long term. And that's why we have to push the field. I think mid-career and late career people really have to try to push the field. I went to a workshop. They have critical dietetics, which was in Nova Scotia when I went, and they had somebody who came from New Zealand and talked about even framing asset-based in your articles. And I thought that was critically important. Part of it is how do we speak? Years ago, people talked about asset-based community development, that we talk in the language of needs. And so, I mean, even in this talk, I've talked about needs and then moved into. And sometimes, honestly, at this point, there's a lot of different ways that you can try to intervene. And some of them are in articles, and some of them are in the work that you do, the boots on the ground, direct work that you do. Because it does take shift in the field, but honestly, shift in the field is slow. And just like, you know, I was thinking about some of the justice work that people did. You know, it's slow. It wasn't like, you know, that everybody was like, okay, here it is. You need to change right now. It's slow. It's incremental. And I think we need to understand that. I think the lowest hanging fruit from my perspective is reframing articles to talk about strength-based approaches. Like we always talk about the community and deficits. And so part of it is that people have to understand deficits because that's the need. But the community is a system, a complex system that has good things and bad things. And then also who's to blame. I think that's where structural violence, because even if you, and there was a teenager actually in a community that I worked in, it was about 15 years ago, and I was presenting on the community about low food access. And this young person actually stood up and challenged me because it was like, we're not just a bunch of people, you know, that with poor stores. And it was like, well, I didn't mean that, and that's not what I'm trying to say, and I'm trying to talk to this audience, and it's like the internal conversation and this and that, and it's like, well, it's no excuse, to start thinking about how to reframe, and that's what the Liberation Nutrition Lens is doing. What's the source? Structural violence. That a lot of these problems were caused because of structural violence, but I didn't get to the asset resilient part as much in this, but part of the Liberation Lens is that community has strengths. If we're going to achieve equitable, we have to understand, like Imani Village is a strength-based project. It's not a deficit project. It's using community resources. For a church to buy 30 acres is something that honestly we can't do. And so I think the first is in paper, so reframe, and then also work with projects that are conceptualized by the community, not always. How do we write research studies on interventions that were developed by the community, not interventions that we think of? So I think that those are two things that can be, I don't want to say smaller things, but things to start. And honestly, I've been trying to work towards that in my own writing. Stop, it's down and out, and this is a down and out place. Well, guess what? It has faced some complex challenges because of structural violence, and that's what we need to say. But even in the face of that, people have continued to persist and survive and persevere.
Thank you.
Okay, great. Okay. Mm-hmm. Yes, they do, yeah. Yeah, part of the, and I have sort of two thoughts on that. One is, the benefit of being at a hard money institution, even though we have to get grants, you know what I mean? Like we have to get grants. Unlike being in a hospital where people are on soft money, or I think it's our hard money, because a lot of times we spend in teaching in hard money institutions, state institutions, and part of it is, I think, working together to move the field. Because you can't teach, we were talking about this earlier, you can't teach what doesn't exist. And things have to be in papers. Because, and I've learned this from personal experience, like even in the National Academy's review. It's like I could show up all day and say, oh, I know this, and I lived in the community this. But it's like, if it's not in a paper, then it's really hard to move the academic field if it's not in papers. And that's why I think that it's really important, because papers also go into classes, students discuss papers, we provide papers, and one reason that I think is that is both who's writing the paper and just the push for the type of papers that we write. And so as a person that's non-tenured, you have to publish in certain journals. But I think as a person, once you become tenured, I hate to say this, but you can justify where you're publishing. And I thought about that for the last year. Again, I don't have all the answers, but there are some journals that people have created that are a little more innovative. And also some of the papers, my first paper was published in Social Science and Medicine. And actually the Social Science and Medicine, it was hard because the person, I got a lot of pushback on the review, but I continued to just persist. It was, my dissertation is on with African American Muslim women, and the questions I got were like, it was on body image in African American Muslim women. It was like so many questions, but I continued to just push. And I hate reviewing papers a lot of times because I'm tired. But I get these innovative papers, I get tenure reviews of people that are innovative, and I'm like, I don't want to do this, I'm tired. But a lot of times it's important that you do it because another person may not understand. You know, like you get these papers, you're like, I don't want to serve as a reviewer, honestly, because I have my own work to do. But I think it's important to just keep on seeding the field, because when you talk about junior investigators are going to submit a paper, and somebody needs to review that paper that understands that paradigm. So part of in training, I'll say papers and more of these theories that we get out into the field. And I think the second is that just like in participatory work, we need participatory teaching. Because you're right, the younger people don't want to hear, you know, like I was just mentioning, somebody told me, it was like, do we have to learn about the health belief model? I'm like, of course, you know, it's a health belief model. And they were like, well, I don't want to, you know, keep on learning about models that don't reflect what I look like. That was developed by somebody who didn't eat, I mean, they didn't. I think they did actually consider people. I don't want to criticize them. I think that they were good public health, CDC, right? Because it's Marshall. I always forget Marshall. Yeah, who developed the health belief model? No,
it was.
I should. Who? No, that's social cognitive theory. And yeah, we know. I can't remember. But we don't want to critique, you know, Bandura. I love Bandura. I love the social cognitive theory. You know what I mean? Like, I love the theory of planned behavior. They're good theories, but we need a broader conversation. I don't want to critique our core health behavior theories. You know, I taught health behavior theory. But the thing is that what you're mentioning is key. And I think in some ways, if we do more participatory teaching, it allows students some flexibility to bring in other ideas that are not in the books that we have. So similar to community engagement, participatory teaching can help. And then also things like community service learning, so people can learn some, you know, more flexibility. But you're right, it's challenging. And so I don't want to stand here and, you know, this is something that's being proposed so it can be tested. And there's more papers to come out to support that structural violence is the cause. So how do we study that more to understand? And that systems, you talked about systems approaches, the importance of thinking about systems approaches and anti-racist praxis. How does that relate to outcomes? But that's a great question.
Yeah, I actually think some of our, with some of the pivot with COVID to make the classes more interactive with virtual or more discussion and getting the students involved. So that's actually a good way to build on that. Other questions? I know we had there.
Thank you so much. I'm just blown away. I really am so honored to be here. Thank you for this. Can you hear me? Okay. So my question is, I'd like to hear your thoughts on folks who have proposed that weight stigma is also a form of structural violence, and that the focus on this weight-centered approach in nutrition and blaming obesity for the, you know, all of the problems is, I just want to hear your thoughts on the whole weight stigma conversation and health at every size, and that, if you can.
Oh, you know. I think, and this is the hard about the, you know, sort of two conversations that go on, because there's a lot of really good books, like Sabrina String's book. And actually, I just heard this guy speak. He just wrote the book, Deshaun. I think, yeah, I can't remember his last. I think it is Belly. Yeah, really good thinking about weight stigma. Of course, Rudd had done work around weight stigma. And did a lot of teaching materials that I've used in teaching about weight stigma and weight bias. You know, it's challenging, and actually one reason why I included severe obesity and just what might be, and again, I don't know, stigma in all forms. You know, and on that slide about different forms of discrimination, weight discrimination is on there. Weight discrimination is structurally violent, period. So, you know, we can't get into, I'm trying to help you and stigmatize you and, you know, you can't help somebody and be structurally violent to them. You can't. So even if you believe obesity is a problem, it's almost like any other kind of discrimination. You can't be an anti-black racist and come and say you're trying to help me. You can't think anti-indigenous racism and then come and say you're trying to help me. It's impossible. You can't think I'm inferior and then say you're trying to help me. So I think that's a given. I think what's difficult is the health at every size debate. And I think it should continue as a debate. Because part of the idea about thinking about the microbiome and other types of approaches to see, you know, is what do we understand about the causes of obesity? And I still think the causes of obesity, I did not include as much, but things like obesinogens and environmental exposures, you know, we've started to dig a little deeper in that, but that's an important area. So are the causes of obesity good? I would argue no. The causes, or in that article about the causes, what some people call it the causes, or, you know, but that doesn't mean they don't exist. I think where the stigma comes in is where people start to think that there is some kind of inherent inferiority and not a societal structural issue. And some people, even if that structural issue was solved, you know, let's even say from birth or 3 generations back, or, you know, because, you know, there's a lot, if we consider history, we just, you know, the origin of some things, even health outcomes, we're understanding more about what happens in utero. So we need to, or even before, you know, so part of it, I think weight stigma is bad, and we have to stop thinking that people are going to fight against that we have individual solutions to structural problems. And so we have to have structural solutions, even if we feel like obesity, that we need to have a lower prevalence of obesity in the United States. I know that there's an argument about weight at any size, and there's an argument about, is obesity really the cause of these health outcomes? And honestly, I don't get into that debate. Because the thing is that I've had interventions of people showing up with a BMI of 40 doing massive physical activity. And so I'm like, that's asset-based. I could show you a video in an intervention I had of people coming with a BMI of 40 doing splits, you know what I mean, like doing physical activity. And I think that that's where, you know, I can't tell what their health outcomes are going to be necessarily, but I do know that physical activity is a good thing and that we need to set up better. So it is a hard debate. The physiological part, honestly, because I don't know, I don't think anybody really knows. We have evidence to suggest A or evidence to suggest B, but my issue is to stay focused. And that's what oppression in any form is restrictive, because if I want you to, how am I going to just discriminate against somebody I'm like, I'm an obesity researcher and now I'm got weight bias. Does that make sense? No, it doesn't. So I think the arguments that they make are super important. We need to stop focusing on individuals like that book, My Body Is Not an Apology. And so, I mean, I'm not a skinny, you know what I mean? So I'm not going to apologize and show, I am a researcher and I have to engage in, we should support people to engage in a healthy lifestyle and a healthy quality of life. So that's where I'm focused, quality of life. That's an excellent question. I don't get into, does obesity cause heart disease? I don't know, you know what I mean? I mean, somebody knows. I won't make that argument. I want to say, there's a lot of evidence to suggest it does. So the health at any size, that's not a debate for me, honestly. I hate to say that, but that's not, it is a debate that is not accepting. I mean, the debate is like, who's right or who's wrong, I don't know. In community, if I show up in community, people are different sizes, they different sizes. You know what I mean? Like, what you gonna do? Make them all the same size? So part of it is like a strange, it's a very, I'm a very practical thinker. The goal is to reduce burden of disease, improve quality of life. And that's my focus. Does that make sense? Yeah. Yeah, I think, because I know a lot of the dietitians don't like health at any size. Yeah, I know I've heard that, like that there's been some rejection of that. I always had NAFA come into my class and talk to the students about just the premise. We have to make room for multiple voices. I think that's really important. But weight discrimination, I can draw the line on that. Weight discrimination, any discrimination in all forms leads to negative outcomes. And that really is my focus. Yeah.
So we have time for one quick question. Does someone have a quick question? Or a question, I should say.
I have one question. So in one of the earlier frameworks or graphics that you showed earlier between, it was...
Can you press? Oh. Thanks, Jamie.
Thank you. So earlier on, you from the discussion around choice or chance, and there was this really cool graphic imagery about creating more chances for people to engage in healthier options. And I was looking at this, and as we've engaged in a lot of work around community and culture, is there any chance that you will see this progression where we reframe the choice or chance approach to have the other big C, culture or community culture, in that, because that often frames a lot of the decisions around food choices.
Mm-hmm. Yeah, I mean, this is a good about culture. And it's like I'm still processing on that, because you're liable to see me show up and link obesity, cardiovascular disease. I do believe, and I probably need to draw the line on that I do think, and this is why I show the difference in the diaspora, I think structural oppression has led to a burden of weight in this population in multiple pathways, and that it is bad. That part is bad. So is the solution more structural oppression? No, is what my argument is. And that goes back to, I think, your about culture. Culture, choice or chance, or culture. And I think culture can be really important in creating new paradigms. But I'm not, and I would love to understand your question. This would be a nice after presentation conversation. I think we have to be careful about culture, because culture is ever evolving. There used to be this paradigm, cultural consensus. Remember that? And culture is forever evolving. And part of that is culture can serve as an asset, and culture and community can serve as an asset. And part of highlighting, I think interventions should allow people to create new cultural paradigms and then also maintain their existing cultural paradigms. When I say new cultural paradigms, I am not a believer of this idea that cultural diets are bad. I reject that totally. I reject that 100%. I don't think that, and this is the structural violence argument. Your meeting. Ooh, okay. Well, and so I would love to talk with you more about that question, because are you saying that culture, community culture, is an asset or strength, or community culture is what creates that negative outcome?
No, and there are multiple perspectives to it, right?
Yeah, I would love to.
That one is an asset. There are multiple perspectives to it. One, that it's an asset, but two as well, when we talk about choices or the options made available to us, a lot of times in the dialogue you'll see a lot of people say, well, that's my culture, right? And so a lot of the options available to me or the choices that I make are inherently based on culture, or the choices that are made available to me are very restricted because they don't align with my cultural preferences. So it's this big iceberg or issue that we have to reframe or address within that conversation of moving from choice to chance. Where does culture fit within that paradigm?
And I think that's really important, because people that study culture and cultural evolution, you can't really separate structural violence and cultural development. Part of what people think of as culture has also been impacted by structural violence. So part of the interplay between that is really important. I think a lot of times we say things are cultural, and they are cultural, so to speak, because we were raised in that culture. But years ago, and they don't do a lot of those studies as much as they used to, people did more studies like in anthropology, maybe they're still doing them in anthropology, about ways of knowing, ways that things have evolved, and part of that is culture. How do you know what you know? And what's your paradigm of thinking around that? And I think, like absolute, I have people all the time, soul food is responsible for, I'm like, soul food? We eat McDonald's, you know what I mean? Like, if you look at dietary consumption data, or you look at availability, it's not like people are going home, and some people are going home and cooking traditional food. But, in the 80s, I was always like, we can, I worked in churches for the health department. I'm like, we're going to change the cultural diet. That was my job. We're going to change the cultural diet. We're going to cook collard greens with turkey. That was like all the things I did, But I think in some ways, I'm not saying that that's not important, but we don't really have a understanding about the contribution of those foods to poor outcomes. I mean, if you look at the increase in fast food or high fructose corn syrup in the food supply, and you see the rise of obesity, so part of this, I don't think we really have, although there's one paper about the cultural diet, I don't think we've quantified, so I'm not one to say, you're like, it's like, well, this is my culture. What is it about that food that makes you feel whole? And I'm not really, it's kind of like, again, I think culture is an asset. I'm very interested in culture as an asset, not a deficit. And so again, that might be, because, in the 80s, that was all like all the manuals. Remember, it was like American Heart Association, NCI, all of the manuals, Down Home Healthy. I don't know if you all have seen that. That was from the 80s, right? So it's kind of like you can't show up, whether it's related to structural violence or it was an inherent cultural asset. I'm really not here to show up and tell you don't do what you feel is cultural. So part of it is like, I think it's important to really think about what are some of the assets within community, what are some of the strengths in community, and how do you leverage that. And I don't think, and this is only my personal opinion, it's not like I have evidence. I think a good approach in the structural violence approach, if I was going to turn structural violence into an intervention, is intervene with people that's acting structurally violent. I think a lot of times we intervene with people who have been impacted by structural violence. So if we can intervene with people that's been structurally violent in those policies, change some of those policies, what could communities do when they're not under somebody's foot? What kind of cultures would evolve? Because really, and George Jerome in 1969, she looked at the cultural diet coming from the South to Milwaukee. Some of this work has already been done, and that's the other thing about, she looked at changes in cultural diets and the impact of that. So, I really have to think about that a little bit more. I don't think that we should see culture and cultural diets as a deficit. They have our people's survival from oppression. They are their survival. And, it's well documented that things have evolved through people surviving from oppression. And so, how do we kind of create an opportunity for people to not be oppressed? That really is my focus, yeah.
And that's
a really good question, yeah.
And that's a great place to end, I think, a great summary. So thank you so much for being here. If we could give Dr. Odoms-Young another round of applause.
Thank you.
And again, thank you all for coming. We do have the lecture recorded, so we'll have that available later. And thank you again. This was such a treat
Thank
to
you.
have you
Yeah,
here.
and it's nice to be and see you in person and not in a little box. Yeah.
Y'all have a great rest of today.